Hi, good morning, good afternoon, everyone. My name is Kapil. Today I'll be presenting findings from a clinical audit on the management of ankle fracture dislocations that we conducted at Sunderland Royal Hospital. These injuries are common but complex, requiring adherence to BOAST guidelines for optimal outcomes. This audit evaluated current practices, identified delays, and proposed interventions to enhance care. My goal here is to share our findings and demonstrate how targeted improvements can make real difference. Let's begin by outlining the scope of the study. Next slide, please. Next slide. Yeah. Well, ankle fracture dislocations are significant challenges in orthopedic practice, requiring prompt diagnosis, reduction, and follow-up care. This audit evaluated compliance with BOAST guidelines, British Orthopedic Association standard treatment guidelines, identified gaps, and proposed strategies for better outcomes. These findings underscore the need for streamlined processes and MDT collaborations. Let's move to the specific focus areas of the audit. Next slide, please. Initially, we focused on three areas: compliance with BOAST guidelines, time to reduction, and image quality. Compliance ensures patient standard safety and standardized care. Timely reductions minimize complications like soft tissue damage, while imaging quality guides accurate interventions. These focused areas represent critical points in the care pathway for ankle fracture dislocations. What methodology we use, as you can see on the screen, we included about 72 patients, which were narrowed down to 49 who met the inclusion criteria, which was closed injuries with gross deformity. This data was extracted from electronic systems like eMedic, Sunrise, T drives, and analyzing metrics such as reduction timings, manipulation practices, and documentation quality. This robust approach allowed us to identify the systemic issues while highlighting the areas for improvement. Let's discuss the first major finding, time to reduction. Next slide, please. A significant finding was delay in reduction, averaging 173 minutes compared to BOAST target of 60 minutes. Prolonged delays increase pain, risk of compartment syndrome, and poor long-term outcomes. Contributing factors included sedation delays and bottleneck in orthopedic availability. Addressing these requires streamlining workflows to meet recommended timelines. Let's now review pre-reduction, manipulation, and documentation. Next slide, please. Thank you. Well, nearly 48% of grossly deformed ankles were manipulated before imaging, deviating from best practices. Poor documentation, including missing neurovascular status and skin integrity, compounded the issue. Accurate manipulation and documentation are critical for safe and efficient care. Imaging also played a vital role, as we'll see next. Next slide, please. Post-reduction X-rays. Sorry, I'm just going to continue previous slide. It's okay. You don't have to shift back. Post-reduction X-rays were, thank you. Post-reduction X-rays were unsatisfactory in 10% cases, leading to repeat imaging and delays. High-quality imaging is essential for accurate diagnosis and surgical planning. Streamlining imaging protocols can minimize delays and ensure timely, effective interventions. Now let's go to the next slide. Thank you. Before we go to the key findings, there's some discussion points I'd like to highlight is These reductions were predominantly done by SHOs, the senior house officers, the junior doctors. 8% of them were done by registrars. Consultant did 18% of reductions, but they were usually second or third attempt reductions where the appropriate or acceptable reduction was not achieved in a post-reduction X-rays. There's some unclear documentation about 15% of who did the reduction. Well, but we do have a data where we have the data for 100% VTA prophylaxis that was achieved upon discharge, and we have been documenting this. Next slide, please. Well, what were the delays and what were the implications of these? Well, delays in reduction and imaging prolong patient discomfort, increase soft tissue damage, and elevate the risk of complications like compartment syndrome. These issues stem from systemic bottleneck, including sedation protocols and orthopedic preferences for reduction. Addressing these delays is essential to improve patient outcomes and streamline care pathways. Let's see what do we propose as interventions. Next slide, please. Like I said, I've already mentioned the implications of delays, increased pain, soft tissue damage, and compartment syndrome. Next one. Next slide. Well, the summary of findings, there, as I said, there's deficiency in documentation in terms of incomplete documentation as to who performed the reduction, neurovascular status documentation, reduction in delays, averaging about more than about 3 hours, and documentation gaps. Though we did manage the VT prophylaxis documentation, there was no clear-cut documentation or a gap in documentation of about 50% as to who did the reductions. Next slide, please. Well, we proposed 3 key interventions: targeted staff education and a standardized documentation pro forma, and revised imaging protocols. Education ensures adherence to BOAST guidelines, emphasizing timely reductions and documentation. Pro forma standardizes reporting, improving clarity and compliance. Optimizing imaging protocols, reduce delays, facilitating prompt diagnosis and treatment. Let's now see where we're heading, what are the future directions, and what we're going to do with the re-audit plan. Next slide, please. Well, a re-audit is scheduled for in next 6 months. It is to measure the impact of these interventions. Metrics like time to reduction, imaging quality, and documentation adherence will assess progress. This iterative process ensures continuous quality improvement, driving better outcomes for our patients. Let's see what were the limitations for the study. Next slide, please. Well, this was a retrospective study. It was a single-centered, and it does have its inherent limitations. Data reliance on existing documentation may introduce bias, while a single center scope limits generalizability. Future studies involved multi-central cohort and prospective designs and will offer more robust evidence and actionable insights, I believe. Let's see what are the key takeaways with this. Next slide, please. Okay, right. Let me just conclude without the slide. I don't know why that's not come up. Well, In conclusion, this audit highlights significant delays and documentation gaps in managing ankle fracture dislocations. The proposed interventions target education, documentation, and imaging to improve care pathways. By addressing these challenges, we can now align practices with both guidelines and optimize patient outcomes. Thank you for your attention. I'm happy to take any questions.
Thank you very much. So I'm not an orthopedic surgeon. I'm an infectious diseases physician specialized in orthopedic infections. And also we do a lot of research in Zurich. And here is a research concerning the perioperative antibiotic prophylaxis, but not in elective cases as shown as here in left, but in special cases with open wounds and with patients who are already infected. I will come to the theory later on. It is a special patient population, patient with open wounds and with ongoing antibiotic therapies. So in these cases, what do you give as a prophylaxis is the study question. In the theory, the evidence-based antibiotic prophylaxis concerns in the orthopedic world first and second generation cephalosporins or vancomycin if the patient is a MRSA carrier, body carrier. This is the overall recommendation all over the world in the NICE guidelines, in the global WHO guidelines, in the American guidelines, and according to the worldwide consensus. This is the basics of perioperative prophylaxis with narrow spectrum antibiotics, and in the orthopedic world about if there is an infection after the surgery, if there is, about 20 or 30% of the pathogens of these future ultimate infections are not covered by the previous prophylaxis during the index surgery. So, but the prophylaxis works if you can close the wound, primary wound closure during surgery. However, in contrast, if you cannot close the wound because there is an open fracture, for example, or the patient is already under antibiotic therapy, which might be even larger than the prophylactic agents, then you risk a selection. And in this special patient population, the proportion of prophylaxis resistant pathogens comes up to 70%. So the standard prophylaxis recommendations poorly work with patients who are already under therapeutic antibiotics for a given surgery or have open wounds that you cannot close primarily during the operation. What is the consequences? Here is an example. I think everyone who deals with infections in the orthopedic world knows it. You can do several debridements for the same infections. In the first and second debridement, you have the primary pathogen, which can be Staphylococcus aureus, but then you realize that as long as you debride, there can be a new emergence of new pathogens in your infection during ongoing treatment for this infection, such as Enterococcus, Enterobacter cloacae, for example. So you have a change of the microbiology of infections during iterative debridements. And then we can assess that. We have assessed that in Geneva. As you debride, here you have in the horizontal axis the number of debridements for a given episode of infections. As long as you debride second look, third look, fourth look, the more is the chance that you have new pathogens in your infected wound. And this incidence of new pathogens is calculated in our center at that time. It was 11%. Well, it is an issue. And these new pathogens also are also typically more resistant than the previous primary pathogens. So what is the solution? So far in the prophylaxis world, the people tended to prolong the prophylaxis. Instead of one dose, single dose, or 3 doses, they gave 2 days, 3 days, 4 days, but it doesn't help. Clinically, it does not help to prolong the molecule of prophylaxis. It can be in a tumor surgery. It can be here in open fractures. Just prolonging the agent does not help. It creates resistant pathogens by prolonging the prophylaxis. And this occurs already after 2 days, after 48 hours. So our idea was, instead of prolonging the prophylaxis, we can do something differently in these open wounds or in patients with antibiotic therapies. Under antibiotic therapies, we can broaden the prophylaxis, but not prolong it. So we make a prospective randomized trial, randomizing between a cefuroxime classical prophylaxis versus a very broad spectrum prophylaxis, including vancomycin and gentamicin systemically. And then we want to see if there is a change or if the broad spectrum prophylaxis can reduce the risk of new pathogens during iterative debridements. This is our lot of study outcomes. And in the primary interim analysis, the first interim analysis after 1 year, you can see at above of the slides, we could say that with a broad spectrum prophylaxis by vancomycin and gentamicin, the number or the proportion of new pathogens decreases significantly. This is already at the first interim analysis. So, with the consequence that you are not obliged to broaden the antibiotic therapy spectrum. So you have less new pathogens, secondary pathogens with a broader spectrum prophylaxis in these patient populations. But the primary outcome, the clinical failures in this first analysis was about the same. You reduce the changing of the microbiology, but you don't reduce with a broader spectrum prophylaxis the overall incidence of clinical failures. And they repeated that after 1 year, after 2 years, pardon. This the same analysis between these both prophylaxis regimes, cefuroxime versus vancomycin, gentamicin, to see if on the overall incidence of failures, there will be a reduction. It is not the case, not for all episodes, not for patients specifically under therapeutic antibiotics, ongoing therapeutic antibiotics, or patients for which you cannot close the primary wounds. So as our preliminary conclusions, the study is going on, it's not finished, but our preliminary conclusions is if you give in selected orthopedic patients, in infected orthopedic patients, the broader spectrum, you can, theoretically, you can reduce the incidence of new pathogens in the infected wound, but you will not reduce the overall incidence of therapeutic failures. With that, I close and I'm ready for questions.
Okay. Right. Good afternoon, everyone, again. My name is Kapil. Today I'm presenting a unique case of spinal tuberculosis in a pediatric patient that we came across when we were doing some projects in rural part of India. This case underscores the challenges in diagnosing and managing spinal TB in resource-limiting settings, while timely intervention can prevent severe complications. Our next few slides will explore the journey from initial symptoms and misdiagnosis to treatment and recovery, highlighting lessons for improving patient outcomes. Next slide, please. Just overview what's spinal tuberculosis or POTS disease. It's a severe extrapulmonary form of tuberculosis caused by Mycobacterium tuberculosis. It accounts for about 1 to 2% cases of tuberculosis cases and 15 to 20% of extrapulmonary TB. In children, delayed diagnosis can result in irreversible spinal deformities, neurological deficits, and chronic disability. This case emphasizes the importance of early recognition and MDT care, particularly in under-resourced settings. Let's see the initial presentation. Next slide, please. This was a 10-year-old boy who presented with chronic low back pain, fatigue, and weight loss over 6 months. Symptoms were initially attributed to mechanical back pain,
Dr.
delay.
Kapil,
Yeah.
sorry for interrupting. Can I reshare the presentation again because we could see some scar on it. So I think that is the technical glitch.
Okay.
So can I
Yeah.
share it again?
Yes. Yes.
Okay.
Yeah. Can we go to the third slide, please? Yes. Uh, so sorry about that. So this was a 10-year-old boy who presented with chronic back pain, fatigue, and weight loss over 6 months. Symptoms were initially attributed to mechanical back pain, and it delayed proper evaluation. By the time of referral, the patient had developed kyphosis, night sweats, and difficulty walking, signaling advanced disease progression. These concerning signs prompted a thorough diagnostic workup, as we'll now explore. Next slide, please. Well, on physical examination, the patient was pale and thin, indicating possible malnutrition and chronic illness. There was localized tenderness over the thoracic spine, and a kyphotic deformity was clearly observed. Neurologically, the patient had weakness in both lower limbs and diminished reflexes. Initial blood counts showed there was mild anemia and elevated ESR, indicating inflammatory process going on in the body. Next slide. The chest X-ray was normal. The spine X-rays showed vertebral destruction and kyphotic deformity. Next slide. We didn't, you can see the MRI image. The MRI did reveal T9, T10 abscess compressing the spinal cord. With the laboratory findings, which included elevated ESR and positive Montauk test, it confirmed tuberculosis exposure. Together, these results established a diagnosis of spinal tuberculosis. Let's review the treatment strategy that was employed. Next slide, please. Yeah, next slide. Well, this patient was started on a four-drug anti-tubercular therapy, which included isoniazid, rifampicin, pyrazinamide, and ethambutol. Alongside ATT, the patient received nutrition support and physiotherapy to address malnutrition and improve mobility. This comprehensive approach aimed to control infection and while restoring multiple functional independence. Let's discuss the progress furthermore. Next slide, please. Regular follow-ups every month monitor the patient's progress. By third month, the patient reported significant pain relief and weight gain and improved mobility. A repeat MRI confirmed reduced abscess size and no spinal cord compression, signaling effective infection control. However, managing such cases in rural settings presents its own unique challenges, and We'll examine that now. Next slide, please. So challenges in rural settings, more importantly, are like limited access to imaging, laboratory facilities, and specialized delays in diagnosis and treatment. Non-specific symptoms like back pain are often misdiagnosed, compounding disease progression. This case essentially highlights the need for better infrastructure, training for local conditions, awareness among communities for tuberculosis symptoms. What are the lessons that have we learned in this? Next slide, please. Well, the key lessons include importance of early suspicion in children presenting with chronic back pain, timely access to diagnostics, and prompt initiation of ATT therapy. MDT care involves radiology, physiotherapy, and nutrition, which is essential for holistic management. Additionally, educating families about the disease and treatment adherence plays a critical role in recovery. What are the possible future directions that we're looking at? Next slide, please. Well, future improvements in managing spinal tuberculosis or essentially extrapulmonary tuberculosis. It includes expanding telemedicine networks to connect rural patients with specialists, introducing rapid diagnostic tools, and implementing community awareness programs. Research into advanced imaging techniques and novel treatment protocols can further enhance outcomes. By addressing these gaps, we can significantly reduce morbidity and improve quality of life for tuberculosis patients. What are the broader implications? Next slide. Okay. So let me just sum up in a minute about the broader implications. Well, this case has demonstrated the challenges of managing complex conditions in resource-limited settings and highlights the role of teamwork in achieving successful outcomes. This underscores the need for capacity building in rural healthcare system and for clinicians to maintain a high suspicion of tuberculosis in atypical cases. These lessons have implications not only for TB care, but also for addressing other chronic conditions in underserved areas. Yeah, that's about me. Thank you for your attention. I'm happy to answer any questions. Okay, so I'm going to discuss a rare and complex case of avascular necrosis of trochlea following a pediatric elbow injury. This case, spanning 10 years, highlights the challenges of managing severe pediatric fractures, emphasizing the trochlea's unique vascular anatomy and its vulnerability to AVN. My aim is to provide insights into diagnosis, surgical decisions, and a long-term follow-up. Let's begin with the initial injury and its impact. Next slide, please. This is a 4-year-old girl who presented with lower humeral epiphyseal separation, a severe growth plate fracture. This injury caused by a fall posed immediate risks to trochlea's vascular supply. Radiographs confirmed the fracture and surgical stabilization with internal fixation was performed. However, malrotation post-surgery introduced additional complications. Let's move to the surgical interventions that followed. Next slide, please. Post-injury, the patient underwent internal fixation followed by corrective osteotomy 1 year later to address cubitus varus. Unfortunately, 5 months post-osteotomy, trochlear sloping was observed, signaling disrupted growth plate development. This highlights the challenges of managing the pediatric elbow fractures, where each intervention can influence long-term outcomes. Let's discuss the further deformities. Next slide, please. Long term, at the age of 14, significant deformities were evident, including avian of the trochlea, medial subluxation of ulna and radius, and malformed radial head. Radiographs revealed fishtail deformity, indicating disruption of bone growth, disrupted bone growth, and remodeling. These complications severely impacted joint function, causing pain, reduced range of motion. Next slide, please. And the next slide. Yeah. So this was the central necrosis and the fishtail deformity that's been shown by the green arrow. Next slide. Next slide, please. The extent of avian was throughout the trochlea, and it did spread to the adjacent metaphysis, and that impacted the structural integrity and function of the whole elbow joint per se. Next slide. Well, let's look at the pathophysiology of avascular necrosis in this particular bone. It's the blood supply is very vulnerable. It relies on vessels passing through the epiphyseal, the physeal plate. Trauma or surgical malrotation disrupts these vessels and it leads to ischemia and bone death. In this case, initial trauma and subsequent interventions compounded vascular damage, causing AVN. Understanding this mechanism is critical for preventing similar outcomes in pediatric elbow injuries. Let's next slide. We'll discuss the management strategies. Management combined initially anti-inflammatory treatment, physiotherapy, and parental counseling. Regular follow-ups with radiographs tracked joint integrity, while therapy focused on preserving mobility and strength. Despite these measures, the patient experienced chronic pain, limited range of motion. This just underscores the challenges of treating avian in pediatric cases. Let's see the functional implications of avian in the elbow. Next slide, please. Well, before we move to relevance, let me just quickly highlight the functional implications. The functional implications on this patient where she had limited flexion, reduced extension pain, and joint instability. This just disrupted all the daily activities and long-term quality of life. Early detection and intervention are vital to preserving function, as demonstrated by this case. And regarding the clinical relevance, well, this highlights the importance of meticulous surgical technique and careful post-op management in pediatric elbow injuries. It emphasizes recognizing the trochlear's vascular anatomy and mitigating the iatrogenic complications. These lessons are crucial for improving long-term outcomes. Next slide, please. Well, the supporting evidence is provided by Wilkins, and it provides valuable context for understanding avian's long-term consequence. This case aligns with existing findings, reinforcing the need for improved surgical precision and follow-up strategies. Further research is needed to refine treatment protocols and minimize complications. Let's see what are the key takeaways of the case. Next slide, yeah. We've seen the functional implications. Next slide, please. Yeah, let's go to the next slide. Right. So in conclusion, this case underscores the complex interplay of trauma, vascular disruption, and surgical decision in developing avian. Early diagnosis, meticulous technique, long-term follow-up are essential to managing these challenging cases. Future advancement in imaging and minimally invasive procedures hold promise for better outcomes. Next slide. Okay. Right. The lessons learned here are importance of protecting vascular integrity during surgery, recognizing early signs of avian and maintaining vigilant follow-up. Additionally, clear communication with families ensure informed decision-making, realistic expectations. Incorporating these lessons into clinical practice can significantly improve outcomes for similar cases. Yeah, that's about me. Thank you very much. I'm happy to take any questions.
So, good morning, everyone. My name is Dr. Siddharth Murekar. I'll be presenting a few presentations today. My topic is improving compliance with the trauma fasting guidelines, and we have addressing the prolonged fasting in trauma surgery patients. This is based in the Princess Royal Hospital in Kings study. The aim was to check for the compliance to the trauma fasting guidelines issued by the trust, and in that process, we introduced intervention that led to significant improvement results. I'll be discussing about that. The primary objective was to assess and to analyze our current practices about the trust pre-procedural fasting guidelines. We had focused this study on the trauma patients, and only the trauma and orthopedics department were involved in dissemination of the study. So the trust guidelines mentions that a patient should be nil by mouth, or he can have septal for less than 2 hours. Although for 2 to 6 hours, there should be clear fluids are allowed, and more than 6 hours, normal fluids and food is also allowed. There were some recent changes wherein septal was introduced, and that's why we had also mentioned that. This was primarily for both elective and trauma patients. Although in terms of elective patients, there are some necessary medications that can be taken around 1 hour before surgery with sip of water and not a bolus of water. Patients are generally offered carbohydrate or carbohydrate-rich drink up to 150 mils 1 to 2 hours prior to the procedure, and I'll mention that in the coming slides about it. So, what is the guidelines mentions, and what are the anesthetic guidelines that mentions about the fasting? So 6 hours of solid food, instant formula, or other milk. So anything that has milk in it is and will be considered food. 4 hours for the breast milk, that is 2 hours less, and for 2 hours for non-particulate and non-carbonated drinks. So Coke or anything are considered food items. Only clear, maybe hot water will be considered clear fluids. The reason for doing this study or doing this quality improvement project, because there are elderly and sick patients and children, and as well as breastfeeding mothers. They should not be left fasted for long. That has negative impact not only in pre-op, they are more anxious, they are more worried because they're starving for longer hours, as well as uh, intraoperatively as well. There is difficulty in the anesthetic induction, and postoperatively, this patient had shown to say more effects in terms of nausea, vomiting, and headaches as well. The reason because there is change in the fasting times is because the order of operating list, from a being very dynamic uh, sector, the operating list gets changed dynamically, and if changed, the wards and the trauma coordinator teams should be normally updated with the new list that will avoid any fasting times. So we did two sets of data collection in this improvement project. First was around 20 patients from 1st of May to 8th of May last year, and we included all the patients on trauma list on our list, including pediatric patients as well. As this was tagged as a service evaluation project, we uh, didn't need ethical approval in terms of going ahead with the study. and there were no patient data or identified data that was used. Apart from that, in the second cycle, sorry, I had mentioned this dates currently. The second cycle lasted for around 2 weeks, and it lasted in July, month of July. So this was the gross age of the patients mentioned in the cycles. You can see that more than 65% of the patients were more than 70 years old in the first, and 25% were in the second cycle. These are the population which are at maximum risk of adverse outcome if they are fasted for too long. In the first cycle and the second cycle, I will also mention about the change we introduced that led to this significant improvement in the results. As you can mention, in the first cycle, merely 16 out of 20, merely 4 people out of the 20 population, that is 20%, had mentioned about the clear fluid intake. That is, you can have clear fluid up to 2 hours, and majority of 80% didn't mention about clear fluid at all. After the change we introduced, this number significantly decreased to 72%, that they didn't mention about it, but 27% did mention. As I can see, there is not a big rise, but any change does takes time in terms of making sure that the change is sustainable in terms of fasting times for this patient. What is the scope of the IV fluids mentioned? So 66% of the patients, they fasted for 6 to 10 hours, that is way above as mentioned the guidelines, and they received IV fluids. And there is a big 85% of the patients in the first cycle, they fasted for 10 to 15 hours, that is way above the normal limits as well. The ones who hadn't even started on fluids are the worst affected. This number reduced significantly to 60% for 6 to 10 hours, and still there is 85% who did fast for 10 to 15%, 10 to 15 hours. So you can see there is not much difference in terms of the people who have fasted for longer time. In the first cycle, 17 people out of 20, that is 85%, guidelines were not followed. Either they were fasted for way longer than what the guidelines mentioned, there were excessive fasting times, and there were no clear documentation on the NBM and clear fluid status. This increased significantly after the change we introduced to 55%, but yes, there's a scope of improvement in that regard as well. Average amount of the time fasted was 6 to 10 hours, and in the second cycle, there were around 45% where the guidelines were still not followed. There was improvement, improper documentation, and excessive fasting times. Specific to mention, 70% of the patients who were cancelled because of the dynamicities of the trauma list, the fasted was 6 to 10 hours, while 29% fasted for a big 10 to 15 hours. This shows the patients who were cancelled fasted even longer than others, and most importantly, 5%, that is 1% in the small cohort of 20, had type 2 DM. Patients with diabetes were fasted for 10 to 15 hours, which is definitely impact the perioperative and post-operative outcome of the recovery. As you can see, in terms of the guidelines that were followed or not followed, in 15% were followed in the first cycle, which significantly rose to 85%, while in the percentage of samples where the guidelines were not followed reduced to not much, that is from 55 to 45%. So this is a example of a trauma list which we occur day to day. There is second is hemiarthroplasty as well for neck of femurs, and there's a small quick procedure for first metacarpal fixation, and followed by one IM nail and metacarpal ORIF. So ideally, this is a whole day list for 5 patients, which we can divide into a morning list and the afternoon list. The afternoon list patient should ideally be given early light breakfast so that they are not fasted from 2 midnight, which is very unlikely they will be going in the morning slot anyway. So the types of lists that ideally needs to be divided as morning list. The orders can be from 2:30. There should be no food, and most people do not eat after midnight, so there's nothing much we need to do. But this patient should definitely have clear fluids until up to, for example, 600 hours or 700 hours before they go to surgery. That is 2 hours before. Afternoon list, they should be given early light breakfast and around 7 hours, at the 7 a.m. And all day list, when there's quite dynamicity in the list orders, the patient who can potentially have a drink should be identified and appropriate advice should be communicated with the ward. There has to be a good communication channel between the theater team, the on-call team, and the trauma coordinator with the surgical wards. So, what did we recommend? So, I will just a second. Okay. So we introduced, I don't know, it's not in the slide. So I introduced a form that the operating team should get filled from the patients while they consent. That mentions about what is the expected time they will go for the surgery, and that will be dynamically discussed with the surgical wards on and off. That will make sure that the patients are not fasted long than expected. So, what are the recommendations? Have adequate list ordering. Having 4 to 5 patients in the NHS in list is expected. If there are 7 to 8 patients, that is slightly more optimistic list about how many patients can be done. This also depends on the type of operation we are going forward as well. We still need better documentation. If there is a golden patient going first on the list, it should be documented clearly that patient should be fasted or 200 hours from the same day and can have clear fluids till 0600 hours. This requires MDT approach as I discussed within the trauma coordinator or the theater coordinator, the operating team, and the ward nurses, especially if there is any change or cancellation. There should be ward-based teaching for the juniors when they document or when they consent the patient. They should be aware about this guideline. We also trialed with some poster campaigns on the wards where everybody was asked, have they fasted more than 600 hours? If so, can we check was a space on the list? We also suggested that they should be induced in the induction program for all junior doctors or nurses that are joining the trust. And there was a trial being run in our center about pre-op carbohydrate drinks at 6 a.m. irrespective of anybody going for the theater, which can we will review if the patient is going on the PM list every 2 hours, that is 8, 10, and 12 p.m. So these are the guidelines, references which we followed through in the study. And thank you so much. I'm happy to take it. We did a improvement project and it had significant results. The topic was how the effectiveness of virtual clinic, that is virtual fracture clinic, in managing suspected or occult scaphoid fracture. This was a retrospective study done at a busy secondary hospital. We did in the Princess Royal Hospital, part of King's Trust. These were the references before we piloted our study. That was clinical and cost implications of using immediate MRI in the management of patients with the suspected scaphoid fractures and negative radiographs. This was a smart trial by Mr. Rua, and the conclusion was the use of immediate MRI in management of participants with the suspected fracture and negative radiographs led to cost savings while improving the pathway's diagnostic accuracy in patients' aspect. This was the same results which we also came across while we did our primary study in Princess Royal. There was another paper published by Mr. Jenkins about a virtual pathway reduced the need for physical review in patients with a suspected scaphoid fracture. So, in simple terms, patients coming to urgent care center with a suspected scaphoid, with having clinical findings of anatomical nerve box tenderness, having pain, can directly go for a low series MRI rather than being seen in fracture clinics sequentially, and then they will be sent by MRI. This will be followed up virtually in a virtual fracture clinic, and if the patients had any positive findings of any type of fractures on the MRI, then they will be booked in the fracture clinic. This in turn did significantly reduce the cost and the clinic time, as well as less people seeing the specialty if they are not needed to. Uh, so we did 2 cycles to firstly check how much the fracture clinics are used, and what is the percentage of patients actually needing a scan in the first cohort. So this is the first cycle. It was a longer study, 10 months from Jan to October 2021, and patients had scaphoid X-ray done in order from the VFC or from the UCC. There were around 242 patients, and the average age was 44. So in the first cycle, I'm sharing the results as well. And as I mentioned, this was the intervention we did before. Sorry. So 30% of the patients had secondary imaging, and the average time from patient coming to the urgent care center to have imaging was around 8 to 57 days. That's a longer around 2 months time. The average was 21 because the patients were seen initially in the clinic and the urgent care center, referred to VFC, then arrange a clinic, and then they were had a scan. So you can imagine the timeline. That's why it was around 21 days on average. 7% of the patients had MRI, while 5% had a CT scan based on the indications. Outcome of the scans were 5 cases out of this had negative scans. 11 of this confirmed. 11 of the scans confirmed a scaphoid fracture, and 10 patients had other injuries. The rest were, as I mentioned, were discharged from the VFC for no clinical findings. So a big chunk, that is 79 patients were discharged who were actually seen in VFC out of 1112. 18% had scaphoid fracture, and 3 cases of this scaphoid fracture underwent a primary fixation, and 46% were discharged with no further imaging. This was the pathway which we introduced. So in nutshell, patients having occult scaphoid fracture presented to UNE, UCC or A&E, and had either of these 3 clinical findings, that is anatomical snowbox tenderness, had a scaphoid compression or telescopy test, or having a scaphoid tubercle tenderness. They were seen by the VFC team, reviewed by a consultant and physiotherapist. There were either of the 3 outcomes that went ahead. Firstly, all the findings were negative, so the patients were discharged and were given advice to come back to A&E or VFC if there are any concerns. Second, the patient had an X-ray which diagnosed a scaphoid fracture, which were directly booked into fracture clinic without wasting any other further clinics. And the pathway which we introduced was patients who were in between, who were in the midway between having a scaphoid fracture or being discharged home, which showed either of these 3 findings. They had an appointment booked for an MRI, directly for a low series MRI, and if there were another 2 probabilities that if they had any clinical findings that needed surgical review, then they were booked in clinic. But if not, they had their MRI, then the MRI was reviewed by the VFC team. Either of these 2 findings were seen. It was normal, and the patient was again discharged back with safety netting. And if it showed positive scaphoid fracture, it was booked directly into fracture clinic. This in turn did reduce the number of clinics that were visited and also reduce the time for having the scans. I will discuss the results. So how a fracture union can be assessed. It's important in scaphoid fractures, which have been notorious to have going to non-union or delayed union quite early, and which has a retrograde blood supply as well. So bone union should always be assessed by clinical investigation. Pain is one of the important findings. Radiological investigation can assist, but clinical findings is paramount in scaphoid fractures. Persistent pain over the fracture site may indicate incomplete or delayed union, but it can be associated to soft tissue injury. Scaphoid fractures unite primarily by bone healing with direct remodeling of the lamellar bone. So we also go for absolute stability with primary bone healing principle. It is same as what you will achieve for intracapsular fractures or intra-articular fractures as well. Those who manage primary bone healing injuries for primary bone healing is difficult to manage, visualize, and it shows quite late in your ready graphs if the scaphoid is going into non-union or it's not healing the way you want. That's why there's a big scope of inter-observer reliability in this. CT with high slice and CT with multiple slice, and there is a possibility nowadays to reconstruct images in axis that can show whether there's any fracture, maybe there's undisplaced fracture, which is not seen in initial X-rays. If there is a suspicion of a bone union, a CT can always confirm that if we need a fracture clinic advisable in the future. So the pathway we introduced, and again we had a second cycle of the data collection for around 3 months. Number of patients were 37, reduced than before, and the average age was 47.2. 4 people couldn't attend the MRI appointment, so they were excluded from the study. This was the average age distribution, and it was around 42.7 as I described. 59% of the population were male and 41 were female, as against 57 were left-handed and 43 were right-handed. Duration from referral to scan. Patient was seen in VFC or directly from UCC until they got a scan was significantly reduced. Initially, it was around 20 plus days. It reduced to 12 days with the introduction of a new pathway. The time from reporting, the time from MRI being done and reporting was not much either. It was around 6.27 days. What was the outcome? The outcome was quite surprising and quite positive outcome, I must say. There were out of these 30 odd people, one patient had a scaphoid fracture, which was caught early. 6 people, that is 21%, had distal radius fractures, and 46% of the patients were totally fine. 13 people, and they were discharged. And this was the most important finding: was 29% of the patients had shown other findings, that is, capitated fractures, or trapezium, or triquetral, or ligamentous injury, which would have been possible on X-ray. So patient outcome: 76 were discharged, 15% self-discharge, they didn't respond, that's why they excluded, and 9% had a fracture clinic appointment booked. Duration from the first presentation, as you can see, the duration for the first one to final outcome was 26 days. That was quite promising. All was done in this period of time, and there are 2 patients who are still yet to be seen while the study was being done in fracture clinic. For conclusion, MRI picked, as you can see, about 50% of other injuries which were missed totally in X-ray. The duration of MRI from referral to being reported and outcome being impacted is improving. Adequate clinical examination will avoid unnecessary investigations, as it will again go for a clinic, again go for X-ray or a MRI. And there is significant increase in the VFC discharges that avoids unnecessary or valuable clinic time being missed. The recommendations, we would strongly recommend to incorporate this pathway either on the electronic patient system or which are hospital you're working, or as a system that should be put in place as a department after mutual agreement. And there should be more awareness, and we had aimed initially to re-audit, but we are still doing this in our primary hospital. And thank you so much. Any questions?
Hello, everyone. Well, I'm going to share now a case report, a case study of management of chronic ACL deficiency in a competitive wrestler. This case highlights the surgical and rehabilitation approaches required to restore function and stability in high demand activity athlete. Next slides, I'll outline the injuries progression, surgical strategies, and recovery process that enable the athlete to return to competition. By focusing on evidence-based techniques, this presentation aims to provide insight or for managing similar complex cases. Let's start by understanding the chronic ACL deficiency. Next slide, please. Chronic ACL deficiency occurs when an untreated ACL tear leads to instability and compensatory adaptations. Over time, these adaptations increase the risk of secondary injuries, such as meniscal tears and cartilage degeneration. For athletes like wrestlers, this condition significantly impacts performance due to rotational instability and dynamic load demands. This case highlights the importance of addressing chronic injuries, ACL injuries, with comprehensive surgical and rehab process. Well, in this particular case, the injury occurred during wrestling match, resulting in immediate instability and pain. Conservative treatment failed to address this athlete's functional deficits, and the knee gradually adapted over to ACL deficiency over a year. This delay increased the complexity of surgical reconstruction due to compensatory damage to surrounding structures. Identifying these changes required a thorough pre-surgical evaluation, which we'll explore now. Next slide. Sorry, previous slide, please. In terms of pre-surgical evaluation, we assess the knee stability, muscle strength, functional deficits. Imaging revealed ACL tear, middle meniscus damage, and rotational instability. This information guided the decision to perform ACL reconstruction with hamstring grafts, lateral extra-articular tenodesis, and medial meniscus repair. This comprehensive approach targeted all aspects of chronic injury. And surgically, what we did was there were three essential components. We did the ACL reconstruction with hamstring graft, LET, and medial meniscus repair. Each technique addressed specific injury aspects, restoring dynamic stability and preventing future injuries. The hamstring graft was chosen for its height and side strength, while LET enhanced rotational control, critical for wrestlers. Next slide, please. So regarding the hamstring autograft harvested using a minimally invasive approach was prepared and sized for optimal fit. This was anatomically placed in femoral and tibial tunnels and secured using interference screws for immediate stability. This approach provides high durability essential for high-demand sports like wrestling. Next slide, please. Extra-articular tenodesis. It adds rotational stability, reducing stress on ACL grafts. This involves anchoring a strip of iliotibial band from the lateral femoral condyle to Gerdy's tubercle. In pivoting sports like wrestling, LED significantly reduces re-injury risks and enhances long-term outcomes. Let's see the medial meniscus repair now. Next slide, please. Technique. Arthroscopic evaluation ensured proper reduction and secure fixation. Preserving meniscal integrity reduces the risk of early osteoarthritis, enhancing athletes' long-term knee health. With surgery complete, rehabilitation was crucial for functional recovery, which we'll discuss next. Next slide, please. About what are the implications of absence of knee degeneration? It's a favorable prognosis, which helps in potentially better full recovery. Rehabilitative approach, rehabilitation allows us to give it a full-blown or more aggressive approach. The tissue quality provides a good foundation for graft healing, and it reduces the risk of early onset of osteoarthritis. Next slide, please. For this particular patient, the surgical considerations were because this is a high demand activity, so the graft must withstand intense forces. We need dynamic stability and we need extreme range of motion in these athletes. So that's why surgical technique must preserve this full range of movement. And this also requires robust integration to allow it for high impact tolerance. Next slide, please. The rehabilitation progressed through 4 phases: pain management, strength training, agility drills, and wrestling specific exercises. At the end of 6 months, the athlete achieved 90% of the strength, demonstrating program's effectiveness. Gradual exposure to the next slide, please. Gradual exposure to wrestling specific movements restored the confidence and reduced risk injury. This is what we look at physiologically regarding the graft integration and healing process. Next slide, please. These were the sports physiotherapist program that we did in terms of how the exercises started, and at the end of 7 to 9 months, when the patient could fully confidently and safely do the agility T test, the patient was discharged from the sports physiotherapists. Next slide, please. Well, we also have to consider the psychological barriers that we have, like the fear of re-injury, performance anxiety, and this needs to be addressed. These were addressed through confidence building exercises and visualization techniques. Reconnecting with the athlete's wrestling identity through team integration played a critical role as well. These strategies ensured holistic recovery encompassing both physical and mental health. Next slide, please. Long-term monitoring and prevention. We did this by regular strength assessments and neurovascular training, which help maintain knee stability and prevent compensatory injuries. Wrestling specific techniques, modifications such as stance adjustments, it helped to protect the reconstructed ACL. Next slide, please. These were the preventable strategies. Essentially, they were devised and designed with the help of sports physiotherapists, the coaches, and the experts, which help the wrestler to come back to the sport. And we did some preventive strategies which enabled sustained performance while reducing the re-injury risks of this particular surgery. Next slide. I think we're done. Future consideration, genetic factors. It may influence ACL healing and graft integration, but there's not much evidence yet to show that. Robotic assisted surgery, that's also another interesting field that is being explored, but it's still in a very nascent stage. Wearable technology, we've got a lot of wearable technologies now, but we am not sure we have gone to a stage where we still can look at knee kinematics in terms of wearable technologies. Next slide. Yeah. That's it. Thank you for your attention. I welcome any questions.
So, another interesting study which I would like to present now is the improvement project we did on MRI request communication with the radiology department for suspected cauda equina syndrome or flash cord compression. This was another study done at the Princess Royal Hospital, part of King's Trust, and this is what the authors mentioned. So I'm going through this of the topics in today's presentation. We'll have a brief touch on the background, why we are doing it, how we proceeded with going with the data collection in terms of the MRI request, and we'll share some recommendation on how we can improve. This can be generalizable to other trusts as well. So, sorry. Yeah. So the background, suspected cord compression and cauda equina do go hand in hand. Although not every cord compression is cauda equina syndrome, but they are very common presentation in any of the hospital, especially in NHS. As MRI is the only radiological parameter that can uh, rule out suspected cord compression, clinical findings are not uh, what you can say diagnostic or can rule out cord compression according to the latest BAS guidelines as well. And it's almost a daily job on your electronic patient records or on your paper records that you have to request a scan if you're suspecting a patient having cord compression, and that needs to be approved, or in UK we call it vetted by the consultant radiologist. Generally, because it's a common presentation to present with back pain and having one or either symptoms or red flags of cord CES. Although CES in itself is pretty rare, and patients having CES going for a surgery is also less than, it's a single digit percentage. So we have more than one patient who presents with a variety or spectrum of presentation, and ideally they need the scan on the same day. Although we have very limited slots in terms of there are two dedicated slots where we did the study for cord compression. If there's something else and it's not going forward, then we can get the slot. But ideally there are only two dedicated slots for cord compression. So the problem is whenever the patients with back pain or one or the other symptoms are requested for getting a scan by the clinicians, they in most of the cases used to failure to communicate properly with the radiology department on the urgency or the immediate scan which they need for the patient. What happened was this led to patients not getting the scan maybe same day or the next day. A delay more than 48 hours doesn't impact outcome if the patient is having CES, because there may be irreversible neurological deficit. Uh, so this delay in adequately communicating and delay in vetting, delay in properly flagging it up led to, if there's a patient with actually having a CES, will have a delay in transfer to neurosurgical team and having a definite care. So uh, we did this study based on this important topic. I will just give a brief example of how the request uh, were had, how the patients had what you can say wrong timed request. On one of the dates, the patient had two requests, and out of that, one had cord compression. This was delayed or because the documentation wasn't proper. Same happened in August. There were four MRI requests. One patient had cord compression. So you can imagine we have to get four requests, and only one will have the actual pathology. The other three needs to be scanned in order to rule out. So on both the dates, the cord compression had MRI and PM list. However, they had more symptoms than others for cord compression. So the data collection for the first cycle ranged from 1st of May to 31st of August. That's a 3-month study. And the second cycle, we gathered the data in October after we introduced the changes we had recommended from 1st of October to the end of October. The data collection was based on the appropriate clinical history, whether the patient had the duration mentioned, whether it was traumatic or a traumatic back pain, and had significant medical history. We also mentioned about we also collected data based on if the documentation had a post-void scan and bladder scan mentioned. These are all indications on based of your GUFT and your BAS guidelines. Focal neurology, what is the PR examination, whether the tone was present or not, whether there was any saddle anesthesia present or not, or numbness, and difficult to void, or if there was any incontinence, bowel or bladder. The aim was to develop interdepartmental communication to improve, which it was already there in place, and the foremost agenda was to ensure the patient safety, as a delay in getting a scan, delay in definitive management does impact your outcome according to the BAS guidelines as well. Um, It's a time-sensitive communication. Any delay will impact the outcome and the transfer to the neurosurgical team because we were a DGH and this has to be transferred to another hospital which had neurosurgical service. Our aim was to improve the MRI request and to triage of cases that require urgent scans. I'll show an example of a improper or a inadequate request. Sitting in a MRI room, someone sending a request like this, you can't consider that this needs urgent scan that will impact outcome. So below numbness, fecal incontinence, and query cauda, equina, and cord compression. What was the onset? What the duration? Was it traumatic? Traumatic? The patient and neurology. There was nothing mentioned, and you can see as well. Uh, they didn't book a transport. Patient having query cord compression, and you're asking the patient can kind of transport in a chair, which is not the best way going forward. Another example you can see in October, the clinical details mentioned were suspected cord compression as per neurosurgical advice. Again, suspected cord compression as per neurosurgical advice, which was definitely improper. Vertebral level, lumbar. They didn't mention about L3, L4, what level. And method of transport, chair. So you can imagine how the inadequate request can lead to patient radiologist thinking that it's not an urgent scan. So what was the recommendation we did? And I'll tell you about the results after that. So routine SHO teaching, we made sure that we have sequential discussing of the red flags, how we should document for cauda equina in our trauma meetings, and especially in induction. Early decisions from the trauma or theatre team regarding the triaging. If there are 4 requests in the trauma meeting with all the consultants present, we can triage who will go first, who will go second on the basis of clinical findings. The SPR on call should review the status, whether they are being scanned or not, and also liaise with the MRI radiographer about the urgency. If there is any vacant slot, that needs to be approved for the cauda equina, suspected cauda equina syndrome. And also liaise with the EPR team if we can include the red flags of cauda equina while mentioning about about the request. Sorry. So we did 2 cycles. So first, it was a good population of 51 in the first, while 32 in the second. Patients with actually having a cord compression were 5 in the first cycle, and in second it was 3. There is a reduction in them. And number of patients with multiple requests were 10, and number of days with multiple requests was 7. The important thing is this is a significant reduction in the results. Is significant reduction in the what you can say, multiple requesting for scan is incidence of positive MRI for cord compression on same day of multiple requests was 2 initially. And although it's a small number change, but reducing the number of incidence of positive scans on the same day of multiple requests is 1. So that has reduced significantly. In terms of the data collection, so only 13 requests were appropriate, while it changed to, you can see, 17 requests in the second cycle. The inadequate request reduced from 62% to 37. That's a good reduction of the inadequate request, and there were no clinical history mentioned in 11% in the first cycle, which reduced to 9.38%. In terms of findings, so doctors mentioning about important clinical investigations. Initially, it was 0%, and it rose to a good amount of 16 requests in the second cycle, while the inadequate request also reduced from 98% to 43%, which is a significant reduction. And there were 2 requests, that is 6.25%, who had no information. It was one in where we need to improve still. So what were our discussion points were, there was significant improvement in the MRI request, which rose to 50% as compared to first cycle. There is a better triage and prioritization of patients after introducing the change we discussed, and we haven't achieved 100%, which should be our goal. There was a significant reduction, but we are still to go for getting the 100% mark. So the challenges which we faced, and as we look forward, the challenges which others will face as well in terms of uh, doing this study is some shifts are really busy for on-call team. For example, in one of the days on October 21st, we had 7 patients with query cord compression. It's difficult to triage all of them. If we have 2 slots, we don't have enough slots. Even if we try to go it in 3 and 1 day, it will be still for 24, 40-hour delay for the other 4. And the problem was new colleagues, they are not aware. As they mentioned about cord compression, that's it, but nothing else. That's inadequate for radiology to vet the scan. Yeah. And yeah, that was the study. Thank you so much. If any questions, please let me know.
Now I'm presenting the protocols that we have in our trust regarding initial management of prosthetic joint infections. Well, PJI is a severe complication of joint replacement surgery requiring prompt diagnosis and treatment. This presentation highlights diagnostic criteria, emergency management strategies, and role of MTT in improving outcomes. By focusing on these elements, we aim to reduce morbidity and optimize patient recovery. Let's begin by discussing the key criteria for diagnosing the PGIs. Next slide, please. Right. So it's diagnosed by using major and minor criteria. The major criteria are 2 positive periprosthetic cultures with the same organism or sinus tract communicating with the joint. Minor criteria include elevated CRP, ESR, synovial fluid analysis, which shows increased WBCs and polymorphonuclear cells. Positive histology or a single positive culture may also support diagnosis. These criteria provide a structured approach to detect PGIs early. Let's review the diagnostic methods. Next slide, please. So this diagnosis involves blood tests, aspiration, imaging, and intraoperative biopsies. Blood tests evaluate inflammatory markers like WBC count, CRP, and ESR. Joint aspiration confirms infection with fluid analysis. Imaging identifies joint loosening or infected-related changes. Finally, collecting 5 intraoperative biopsy samples ensures microbiology accuracy. Withholding antibiotic before tests, unless the patient is septic, enhances culture sensitivity. We'll discuss the emergency management of the PGIs now. Next slide, please. Emergency management begins with patient assessment and prompt diagnostic tests. Blood tests and joint aspiration guide initiates treatment, while arthroscopic washout removes infected material and reduces bacterial load. Broad-spectrum antibiotics are initiated after culture are obtained, adjusted later based on susceptibility testing. Early intervention minimizes complications like sepsis or prosthetic loosening. Let's explore the role of MDT in managing PGIs. Next slide, please. MDT ensures comprehensive care for PGI patients. This team includes infectious disease specialists, microbiologists, orthopedic surgeons, pharmacists, and specialist nurses. We have bi-weekly meetings which facilitate case discussions and collaborative decision making. Each member plays a critical role in diagnosis, treatment, and follow-up, improving patient outcomes. These are the timings and the usual day that we have these meetings. Next slide, please. So infectious disease specialist, essentially the microbiologist consultant, is a guy he guides us with the antibiotic selection and therapy duration. They consider pathogen profiles, patient comorbidities, drug interactions to create individualized regimens. Their close monitoring of treatment response ensures effective infection control while minimizing adverse effects. This role is vital for balancing aggressive treatment with patient safety. Next slide, please. So they contribute by identifying causative organisms using culture, gram staining, and advanced diagnostics like PCR. They test the antibiotic susceptibility and interpret culture results to guide therapy. By assessing biofilm formation, microbiologists help refine treatment plans, especially for infections involving prosthetic surfaces. The expertise ensures accurate diagnosis and effective antimicrobial use. Let's look at the orthopedic surgeon's perspective in the next slide. Well, as orthopedic surgeons, we assess infection extent, prosthetic stability, and tissue damage. Acute infections may be treated with debridement and implant retention, with chronic cases often require staged revisions. Surgeons also oversee postoperative care, ensuring effective wound management and rehabilitation. Their decisions significantly influence functional outcomes for PGI patients. Let's look at the collaborative approach in the PGI management in the next slide, please. The MDT collaborates through case presentations, discussions, and treatment plan formulations. Each member's expertise contributes to a comprehensive individualized plan for a patient. Regular follow-ups and adjustments ensure care aligns with clinical progress. This team-based approach enhances diagnostic accuracy, optimizes treatment, and improves long-term outcomes. Let's summarize the key points in the next slide, please. Right. Okay. Right. Okay. Let me just talk through this. Well, in conclusion, the PGI management relies on early diagnosis, MDT care, and evidence-based interventions, diagnostic criteria, emergency protocols, and MDT pathways ensure consistent high-quality care. By integrating these strategies, we can reduce the complications, improve recovery, and enhance patient outcomes. Thank you very much. I welcome any questions.
So today I will present about vascular injury with inserting anteroposterior locking screw of retrograde near femur as a case report. The incidence of pre-prosthetic fracture following total knee arthroplasty continue to rise as the number of knee arthroplasty procedure increase. There is a significant mortality and morbidity associated with distal femoral periprosthetic fractures. These fractures remain challenging to treat owing to several factors, including the advanced age of the patient and the difficulty in achieving stable fixation in patients with poor bone stock and osteoporotic bone quality. Locked compression plating and intramedullary nailing or combination of both are the most commonly used treatment options. Intramedullary nailing is preferred by many surgeons because it is minimally invasive, low shearing, can augment plate fixation and allow early weight bearing. Vascular injury resulting from the placement of proximal locking screw are uncommon and might go undetected, but might lead to potentially life-threatening complication according to Barnes 2002. Risks for vascular injuries with proximal locking screw insertion include inadequate soft tissue protection, like freehand technique, small skin incisions, trauma and associated fracture might increase the risk of displacing the neurovascular structures. The presence of significant collateral blood vessels in elderly population. Reviewing the literature, Handolin et al. 2003 reported 2 cases of arterial vascular injury with retrograde near femur during distal femoral periprosthetic fracture fixation. In the first case, the bleeding was from one of the anterolateral branches of the deep femoral artery, 3 cm above the most proximal locking screws. In the second case, the bleeding was from the main trunk of the deep femoral artery at the level of the drill hole. Embolization with fiber coils was successfully done and the 2 patients completely recovered. Eden et al. In 2023 examined the optimal location for inserting proximal interlocking screws in retrograde nail femur fixation, and he stated that the safest level for the proximal locking screw is 1 centimeter superior to the lesser trochanter, and 1 centimeter inferior to the lesser trochanter is dangerous for neurovascular structures and should be avoided if feasible. The injury is not only from direct penetration, but also the drill bit might encircle the muscles, creating an avulsion injury in these vessels. Vascular damage following this injury is observed in the literature, typically indicated by low postoperative hemoglobin levels or thigh swelling. We presented our case report 2024, and our case was 82-year-old female patient presented with periprosthetic supracondylar femoral fracture after a mechanical fall. She has background of total knee replacement on the same side of the injury 10 years ago. She has a good level of mobility and walking unaided. There is no other significant past medical history. And this is the images of the fracture, AB and the lateral distal femur showing oblique fracture on top of total knee replacement. The decision taken to use retrograde intramedullary nail to stabilize the fracture. The patient underwent surgery on the following day of the injury, of the admission. We utilized Sense's retrograde nail with diameter of 11 mm and length 380 mm. We carried out a minimally invasive procedure and with assisted open reduction utilizing cable for provisional fixation. The distal end of the IM nail was secured using spiral blade and an interlocking screw, while 2 screws were used to lock the nail proximally. The 2 screws were secured at the level of the lesser trochanter. The operative time was 90 minutes, and estimated intraoperative blood loss was about 300 ml. Post-operative, and when the patient entered the recovery room, we noticed swelling at the location of the proximal interlocking screws. The primary diagnosis was hematoma located at the level of the proximal screw due to muscular branch injury. Our primary diagnosis was this by this time. Due to the patient's stable hemodynamic condition and the presence of small swelling, we decided to perform compression and monitor the patient overnight. The following day, unfortunately, the swelling continued to increase and the patient hemodynamics started to change and hemoglobin dropped from 160 to 92. An urgent CT angiography was ordered, which revealed, as we can see from these images, swelling from active bleeding from anterior branches of the profunda femoral artery with ongoing bleeding. The case was deliberated by this time by radiology and the vascular department, and the decision was taken to proceed with embolization under the care of our intervention radiology department under local anesthesia. Afterwards, the patient was transferred back to our ward and closely monitored after the intervention. We administered 2 units of blood and rehabilitation and mobilization start within the patient pain tolerance. The following days, the patient swelling had diminished, and his vital signs had returned to normal. The patient commenced comprehensive physiotherapy regimen on the 3rd day and discharged home at the 7th-day post-op. Reflection. Following the incident, we started to use this 5 ml syringe tube as a safeguarding cover for the insertion of the proximal locking screws. We become more careful during the dissection and the preservation of the soft tissue following the incision of the skin. Drilling of the proximal screw as well as inserting of them will happen through this radiolucent syringe. This technique was described by Perron et al. In 2020. Conclusion: vascular injury to the femoral artery branches due to insertion of the proximal screw is rare, but potentially dangerous complication, particularly in elderly individuals with multiple comorbidities and virility. This complication requires high degree of suspicion, particularly if the proximal screws were inserted through a small skin incision. There is no definitive safe zone. The most effective method to prevent this rare complication is by ensuring meticulous protection of soft tissue. Rapid intervention is crucial in managing this complication, as more observation is often insufficient and the proper early intervention on time is the best. Thank you. I have finished the presentation. Hi again. It's my pleasure to present my second paper about percutaneous fixation of traumatic sacral fracture. Again, my name is Mohammed Ragab Shalan, one of specialty doctor in trauma and orthopedic in Vascular Hospital. This is my reference and acknowledgements. This agenda today will be about surgical anatomy, sacral biomechanics, diagnosis, radiological assessment, classification, management, and our paper presentation. About 45% of pelvic fracture are associated with sacral fracture. Isolated traumatic sacral fracture are very rare with pelvic, and 95% are associated with pelvic fracture. So only 5% are isolated. Commonly high energy trauma, except with osteoporotic fracture in elderly patient, which might result from low energy trauma. 30% were missed or delayed diagnosis, which now become more recognized with CT scan utilization and trauma survey. 25% are associated with neurological injury. Vertical sacral fracture is the most common type of sacral fracture. Regarding the anatomy, the sacrum is a triangular bone with concave ventral surface and concave dorsal surface. Sacrum articulate with L5 lumbar vertebrae proximally and coccyx distally, and ilium bilaterally through sacroiliac joint. It has a complex anatomy formed of 5 fused vertebrae, which give here reinforced bone block attitude. 4 pairs of sacral foramina, which are exit of sacral nerve root bilaterally. The anterior root are responsible for ankle plantar flexion and the bladder and the bowel control, while the posterior roots mainly sensory innervation to the buttocks. The sacral foramina anatomically divide the sacrum into sacral ala lateral to the foramina and sacral body medial to the foramina. Biomechanically, the sacrum is the main element of the pelvic integrity through a strong osteoligamentous connection with both iliac bones. As we can see here, this is posterior sacroiliac ligament, which is the strongest ligament in the body, which is found on the dorsal surface of sacroiliac joint. We also have the sacrospinous ligament, which is prevent and resist external rotation and external rotation. We have also sacrotuberous ligament, which resists both rotational forces and shearing forces. Biomechanically, the sacrum acts as keystone for the spinopelvic junction. An intact sacroiliac osteoligamentous complex allows optimum load transfer from the axial skeleton to the pelvis to the lower limb. This complex is well designed biomechanically structure in that it can resist prolonged and powerful forces and can support weight-bearing forces from the spine to the lower extremities during most activities. Diagnosis of sacral fracture need high degree of suspicion of sacral fracture, especially with high energy trauma. As it is high energy trauma, the patient need to be managed according ATLS protocol. Comprehensive and repeated neurological examination should be done involving BR examination, full lower limb neurological examination, anal sensation to exclude cauda equina syndrome or other neurological injury. Soft tissue assessment of the pelvis is mandatory, and assessment of presence of any bruising, swelling, morally lavely lesion, and illustration over the sacral area or pelvic region increase the suspicion of sacral fracture, plus have an important role in management plan later on. Rectal and vaginal examination is mandatory to exclude open fracture, which will decide the management plan. Radiological evaluation. Unfortunately, X-rays misses up to 70% of sacral fracture, so it's critical to adhere to a systematic and rigorous approach in evaluating pelvic images. As we can see here, this is EB radiograph of the pelvis, and it is normal. So we need to go to assess certain lines which represent maintaining the integrity of the pelvis. So if we can see this red line indicate iliopectineal line, and this purple line indicate ilioischial line, and we have this yellow line Shenton line, and we have anterior and posterior walls, and we have also this white dotted line indicating sacral arcs, and we have the green dotted line indicates the teardrop. Any discontinuity or disruption of these lines indicate either pelvic fracture or sacral fracture. If we have suspicion, we need to have another additional views, which is called inlet and outlet views. But the CT scan is the main choice in sacral fracture diagnosis and evaluation. CT, as we can see here, this is CT axial cuts showing sacral fracture, which is the gold standard of diagnosis. But not only diagnosis, CT scan is very important in classification, preoperative planning, and excluding the sacral dysmorphism. Sacral dysmorphism is an sacral anatomic variant present in 20 to 30%, 30 to 40% of adult patients. There is some signs of sacral dysmorphism in X-rays. As we can see here, this normal X-rays found to the left and dysmorphic sacral X-rays found to the right. This signs is like the arrowhead pointed to the level of sacral body, which is higher than the iliac bone level, which is supposed to be normally recessed in the pelvis and at the same height of the iliac bone, and the arrow pointed to the mammillary body, which is not present in normal pelvis. Also, this circle pointing to the sacral foramina, which in case of sacral dysmorphism will be misshapen, irregular, larger size, and pointed into different direction. We can also see this a remnant of S1, S2 disc, which is not found in the normal pelvic X-ray. If we have these signs, we need to go for better evaluation of sacral dysmorphism in CT scan, because actually, if we missed diagnosing sacral dysmorphism, there is a high risk for neurological injury if we used iliosacral screw for fixation, because actually, as we can see in the right, this is a normal CT scan of normal pelvis, so there is a sufficient bony corridor for the iliosacral screws, but to the right, you will find the red tube touching the neural foramina, and there is a higher risk for. So diagnosing sacral dysmorphism will help us to decide if it is safe to go for iliosacral screw fixation or not. Classification. There is many classification for sacral fracture. Some of them just simple like Dini classification, which is the most widely used and simple classification, classifying the sacral fracture according to the fracture line relative to the foramina. So Dennis type 1 is a sacral fracture lateral to the sacral foramina, and Dennis type 2 is sacral fracture through the foramina, and Dennis type 3 is sacral fracture medial to the foramina. And Dennis type 3 is highest risk for neurological injury, but Dennis type 1 is the most common with the least risk of neurological injury. There is another classification, which is sub-classification of Dennis type 3 fracture, which is very important because actually any traumatic sacral fracture that result in complete separation of the pelvis from the lumbar spine should be considered as a spinopelvic dissociation, and has many shapes like U-shaped, H-shaped, lambda-shaped, or inverted Y-shape. And it's important to define and diagnose this fracture because actually it needs a special fixation method, which actually was outside our inclusion criteria in our paper, as I will mention later on. There is another classification called the tile classification, which classify sacral fracture as a part of the pelvic injury. It mainly depends on the stability of the fracture. So tile A, it is mainly fracture involving non-essential structures of the pelvis. So the pelvis is rotationally and vertically stable. But in tile type B, the pelvis is rotational and stable, but vertically stable. Then tile type C, the pelvis is rotationally and vertically unstable. And the sacroiliac complex is an integral part of this classification and mainly decides the degree of instability of the pelvic injuries. There is another classification called Young and Berger's classification, and it mainly depends on the direction of the force. So we have anteroposterior compression injury, lateral compression injury, and the vertical shear injury. Management plan. As we mentioned before, sacral fracture mainly resulted from high energy trauma, so the patient need to be managed according ATLS protocol to restore the hemodynamic stability. So unstable patient, unstable fracture need first provisional maneuver like pelvic binder, pelvic fixator, T-clamp, or pelvic embolization or packing to restore the hemodynamic stability. Once the patient is stable, we need to go for assessment of the fracture. Either it is stable fracture, can withstand physiological load, and there is no displacement or pelvic instability. So this stable fracture can be managed conservatively without surgery with weight bearing as pain tolerated, or unstable fracture, which is part of the pelvic instability or displaced with physiological loads. Anatomic reduction, we can go for percutaneous fixation, which is the gold standard, or if there is a displacement more than 5 millimeter, we need to go for open reduction, internal fixation. We published our paper about percutaneous ilioilial fixator versus percutaneous iliosacral screw in managing unstable sacral fracture. It was a prospective randomized controlled trials. We excluded fracture with a spinopelvic dissociation or associated neurological injury. We have included 51 patients with a minimum 1 year follow-up. There is no statistical difference between the two patient groups regarding clinical outcome, radiological outcome, operative time, blood loss, post-operative complication, or need for another surgery. There is a higher risk of radiation exposure with iliosacral screw fixation. Both techniques have a comparable functional and radiological outcomes in managing traumatic sacral fractures without pelvic dissociation or neurological injury. The first arm of the study was about iliosacral screw, which is the current gold standard of treatment, which can be done in prone or supine position, but needs certain prerequisites like preoperative planning to exclude sacral dysmorphism, to make sure there is secure pathway for iliosacral screw, proper bowel preparation, radiolucent table, and good visualization of 3 views, lateral, inlet, and outlet of the pelvis. And anatomical reduction is a mandatory before iliosacral screw fixation. This is the first case. 27-year-old male had a traffic accident, presented with tile type C3 fracture. It was closed injury. As we can see here, the first X-rays of AB, inlet and outlet, then CT scan assessment showing comminuted vertical fracture. Then the patient went for anterior fixation of the anterior ring through symphysial plating and fixation of sacral fracture with iliosacral screws, as we can see here. So our paper mentions that percutaneous iliosacral screw might be unsafe in case of high risk of neurovascular injury with L5 injury in case of sacral dysmorphism, displacement more than 5 millimeter in experienced surgeon, because it need a longer duration for learning curve, highly dependent on X-rays, which increase the hazards of radiation exposure, and also the high quality X-ray might be not available in developing countries. And there is a query concerns about the efficacy of sacral screws fixation in vertical sacral fracture. So the other arm of the paper about ilioilial fixator, which in our paper might be available and a good option instead of iliosacral screws. The technique was introduced in 2011. It is the idea of fixing the sacrum with the spinal instrumentation, so pelvic surgeon, spine surgeon fixing the sacrum. It mainly depends on 3 concepts. The first one was McCord pivot point, and according to McCord et al. In 1992, for any implant attached to the sacropelvis at least part of the fixation tool should pass anterior to the pivot point, which is the axis of rotation at the lumbosacral junction and lays at the intersection of middle osteoligamentous column and L5S1 disc to rigidly fix this area against rotational forces. Second concept has been developed by Marvin Tile, and this concept indicating that the posterior sacroiliac complex is similar to suspension bridge. The posterior sacroiliac ligament act as suspension cables, and the posterior superior iliac spine act as towers, and the sacrum act as the bridge deck. And as we can see here in this model and this diagram, the internal ilioiliac fixator resembling the same concept of suspension bridge. The third concept is zone of fixation according to O'Brien. O'Brien et al. 2004 stratified that the strength of the sacropelvic construct depend on the zone of fixation. He divided the sacrum into 3 zones. Zone 1 constitutes the S1 vertebral body and the cephalic sacral ala. Zone 2, the S2 vertebral body to the tip of the coccyx with the caudal sacral ala, and zone 3, the iliac bones. So for any construct stability to be more rigid and improve the fixation, need to extend caudally with more anchor point, and is further increased if instrumentation is through zone 3 with fixation point anterior to lumbosacral pivot point, which makes the ilioiliac fixator biomechanically stiff and stable construct to fix the posterior sacroiliac injuries. This is one of our cases. This is 27-year-old female patient after motor car accident presented with tile type B fracture. It was closed injury. We can see pelvic x-rays, AB, inlet and outlet, and a CT scan demonstrating comminuted vertical sacral fracture. And this procedure is done in broom position with 2 cantilever dorsal incision just medial to the posterior superior iliac spine on the fracture side and on the other side, and then 2 polyaxial or monoaxial pedicle screw can be inserted with lengths between 55 to 80 mm long and 7 mm thick, were applied bilaterally directed towards each ipsilateral greater trochanter. Most of the cases can be done without fluoroscopy, and the construct is finalized with a deep tunnel connecting the 2 pedicular screws, polyaxial screws with rods. This is the post-operative X-rays. Actually, this patient at the end of the operation, manipulation under anesthesia indicated instability in the anterior pelvic ring. So the anterior pelvic ring was fixed with anterior infix, and the last 3 X-rays represented follow-up X-rays after 3 months with the ilioiliac fixator in situ and after removing the anterior infix. Our recommendation, iliosacral screw still the gold standard, and being our recommended fixation method in case of bad skin condition, presence of suspected Morelli lavelli lesion, associated trauma or circumstances that prevent prone position like pregnancy and flail chest. But the ilioiliac fixator is the suggested implant in sacral fracture in case of sacral fracture with vertical instability, any technical difficulties in imaging the fracture like unavailable fluoroscopy, any factors that might obstacle the quality of X-rays. Sacral dysmorphism is recommended to be fixed with ilioiliac fixator. Thank you.